Question number 4. So are you able to see the slide?
Yes, sir. Yes, sir. We're able to see.
So this is the question that has been given. 75 years old, known case of hypertension, 20 years duration, diabetes 15 years with progressive difficulty. Okay. So always analyze the case. 75 years old patient, geriatric age group. This much of simple answering is enough. Okay. So you need not say elaborate answer. Hypertension 20 years with attendant complications or organ dysfunction. Diabetes 15 years, which is also another comorbidity. BHV is voiding difficulty posted for PURP. So if a neglected BHV is there, what can happen to the patient? Supposing he has been having a benign hypertrophy for a long time, he did not know that he can get either medical treatment or surgical treatment. What is the complication that it can lead to?
Urinary
He is not avoiding completely. So there is always
urinary sepsis.
UTI is one, okay.
Obstructive uropathy.
Ultimately, obstructive uropathy and renal failure. Okay. So sometimes the examiners may ask you about this problems in voiding. What are the types of problems? I have told you in the class about the American Urological Society's description of the difficulty in H stands for hesitancy, I stands for intermittency, S stands for small stream or thin stream, F stands for frequency, U stands for urgency, N for nocturnal urination, and there is also should be a D, which is dribbling. Sometimes patient gets dribbling. So his fund is the mnemonic that you can remember to describe the various problems of urination. Okay. And any other associated surgical conditions. This question should always be asked because many people keep on straining and they may develop a hernia or a hemorrhage. So this question also should be elicited in the history. And any medical treatment tried or being continued, like initially some of the small size prostate, before it becomes too large, the surgeons themselves try to manage it with the medications like alpha blocker or the testosterone inhibitor and all those things which we have discussed in the class. So please go through all the medical drugs that are prescribed and their importance in continuation. Supposing the patient is on prazosin, which is an alpha blocker. What is the risk in giving spinal anesthesia for this patient? What drug is prazosin? I told you is an alpha blocker. So can it cause or exacerbate the hypotension because it's an alpha blocker?
Yes.
Yeah, so you must know and you must document. If supposing the patient is not a hypertensive and he is on prazosin just for the treatment of prostate, he may develop hypotension. So you may try to ask him to stop it before you give spinal so that you don't get an exaggerated hypotension in the patient. Okay. And you must go through the records and see the gland size and the lobes involved. Which is the lobe which will be commonly involved in these patients? How many lobes are there?
5 lobes.
5 lobes are there, and which lobe commonly produces obstruction? The median lobes. Okay. So that is the one which is very close to the urethra. So that is the one which will enlarge, and that is the one which will give problem. Okay. The gland size. Why should you know the size of the gland? It is a surgeon's headache, but as an anesthesiologist, why you should know the gland size? What is the normal size of the prostate gland? Healthy normal prostate. 16 to 20 grams. Okay. It can go up to 80 or 100 grams also. So a maximum resection of 60 grams only can be done to prevent severe bleeding and other complications. So if the gland is too large, surgeon may opt for 2-stage procedure. He may remove part of the gland in first sitting. After 2 days or 3 days, he will bring the patient and do it a second sitting. Okay. So for that, you must know the gland size also. And with regard to the comorbidity, hypertension, you must see whether it is controlled or uncontrolled. What are the drugs that he is taking? whether the target organ dysfunction like cardiac, cerebral, or renal, or retina. These are the four organs which can be affected by uncontrolled long hypertension. So you must ask questions with regard to anginal pain or stroke, early stroke and recovered, whether any visual disturbances, or whether he has been diagnosed with any renal involvement like albuminuria and all these things. Similarly, diabetes, you must find out whether it is a controlled or uncontrolled, what are the drugs patient taking, any drugs which need to be modified, and whether the patient again has got any target organ dysfunction. Then musculoskeletal issues like joint mobility of hip and knee and back and spine. All these things you should check and make sure that they are free. And renal involvement due to obstruction and back pressure. That is another issue that you have to find out whether patient has features of renal failure like puffiness of face, edema, legs, and all that. And pre-op investigations, routine for as for any surgery plus serum sodium. I have highlighted that so that you document that and do all the evaluation for, because of age, cardiac, respiratory, CNS, especially for cognitive function, any hearing problem, any visual problem, and effort tolerance. What is his next level? And risk stratification, always mention about the risk stratification because it is based on the chronological versus physiological age. Patient may have maybe only 70 years old, but in its physiological state may be very poor. On the contrary, a 90-year-old man may be physically very fit compared to a lesser age person. So always compare the chronological versus physiological age and severity of comorbidities. So these two things will tell you about the risk involved. And then pre-op optimization of BP, glycemic control and drug adjustments have to be made. And pre-op instructions, NPO, drug adjustment, anti-anxiety, anti-aspiration medications, and blood sugar management is very important in all diabetic patients coming for surgery, especially elective. When you advise NPO, you have to know the blood sugar values. And then intra-op, the preferred technique is single shot subarachnoid block. The advantages, it is technically easy. Mild hypotension helps the surgeon to have a clear vision and early diagnosis of TUR syndrome. And also another point you can add is bladder perforation is easily detected. Disadvantage is prone for sudden hypotension, shivering, and sometimes initial penile erection may cause difficulty in passing the receptoscope. And intraoperative fluid management, that also you have mentioned correctly, not to hydrate the patient too much or preload the patient. And assessment of blood loss, assessment of fluid absorption using the formula. And you must know all about the irrigation fluid, various types. And sometimes from this, suddenly they may ask about a patient with a pacemaker and the importance of pacemaker in a patient coming for TURP, and all about TURP syndrome, clinical features, complications, diagnosis, confirmation, and treatment. And if GA is required, the reasons are patient may refuse spinal or there may be coagulopathy, infection. So in under GA, how do you identify TURP syndrome is the common question the examiners ask you. So post-op management, management of pain, shivering, bleeding, clot resection, retention, and sometimes they may need to re-explore if there is a bleeding. Okay, so these are all the problems that you have to keep in mind. And if you know these points, I think fairly you can manage most of the questions for a short case, right? Okay, you can go ahead with the
Pricing toxicity and other things also you
break
mentioned.
and
Sometimes,
shall we ask
sir, sometimes they have this
Sai-
rule of 60, no, sir.
rule of 60. That she mentioned about the height is 60 centimeters
sir.
and resection time less
Okay,
than
sir.
1 hour. I think she mentioned that.
Unless some
Rule of
people like
60.
to ask it very commonly, no, sir.
Yeah, very commonly they ask you. Another, the third component of rule of 60 is resection of 60 grams of prostate tissue. Okay, three things. Height of the irrigating fluid column is only 60 centimeters from the table or pubic symphysis, as you mentioned. Second is total duration of resection less than 60 minutes. Third is total resection of the weight of the gland is less than 60 grams. These three things they are called the rule of 60 for safe to prevent Turp syndrome. Okay, and Turp syndrome can happen anytime intra-op or up to 24 to 48 hours post-op also if irrigation is continued. So that is another common question. What is the time of occurrence of Turp syndrome? It can start within 15 to 20 minutes of starting the case, or 1 hour after starting the case, or 4 hours post-op, or up to 24 hours post-op also. Okay. Right.
There are other places where Turp syndrome, the splicing toxicity, which can happen. Other surgeries.
Huh?
Any other surgery where such irrigation fluid absorption problems can happen.
Yeah, that is a hysteroscopy, and this the same thing is done for the uterus, ablation of the endometrium. So that is also a procedure which was initially popularized in cases of DUB, where instead of doing hysterectomy, they wanted to ablate the endometrium by irrigation, and that also produced pictures exactly like TURP syndrome. The basic thing is absorption of the irrigating fluid, diluting the blood and causing a drop in sodium, which is the main reason for all the changes that happen. Okay, that is the basic pathophysiology.
TURBT, sir, for some surgeons will require.
TURBT is just a resection or cutting of the tumor that is arising from the bladder, and because the current used is stimulating to the nerve, there will be a jerking of the leg.
Operator nerve.
So operator nerve. So you have to block. In addition, even under spinal anesthesia, this reflex may happen. So there may be need for blocking the operator nerve separately, even after giving spinal. Just like you do the 3-in-1 block, you have to put your long needle next to the femoral artery and insert it up towards under the inguinal ligament, so that you block the operator nerve on that side, right or left, whichever the tumor is. So that is the only problem that we can TURBT.
Thank you, sir. Thank you, sir.
So shall we give